We'll start today the Wednesday session on this great seminars. Professor Patricia Coyle from Stony Brook will be co-chairing with me. I'm Bianca Weinstock-Guttman from Buffalo, New York. Patricia Coyle is a specialist on multiple sclerosis, professor and chair at Stony Brook, and she will present today a very important topic actually for all the people involved in CCSVI, and that's to understand that there are outcome measures required in multiple sclerosis research to follow in order to provide the information on yes, no progression of the disease or improvement of the disease, if indeed we are taking care of MS patients. So Professor Coyle, she will talk about disability-related outcomes in multiple sclerosis.
It's a great pleasure for me to be here with you today, and I think this is a very important session because for anybody interested in clinical trials, and I think that's critical for CCSVI credibility, outcomes are a very important measure, and we're going to be covering the spectrum here. And I'm going to begin by discussing disability-related outcomes. And here are my disclosures. I think they're in your book as well. So when we're talking about disability-related outcomes, this is a strictly clinical measure when we talk about disability. But if you poll healthcare providers and patients, basically this comes down to probably the most important parameter. It will trump relapses. It will trump lesions on the MRI scan. Disability, development of disability, is generally rated as the most important factor to try to prevent. Now, if you look at any of the pivotal trials in MS, either relapsing or progressive, disability is a given key parameter. You really can't do a phase 3 trial without having a disability measure in MS. But an important point, in relapsing patients, if you have a very short-term trial, disability really is not helpful. It's not a valid measure. And what do I mean by a short-term trial in relapsing MS? 6 months or 1 year, you generally will not have a lot of weight put on disability because it's simply too short a time frame. So generally you're talking about 2 years, and that's part of the reluctance to accept 1-year trial data. They really want 2-year data, and they want to know about disability. And typically it's a primary, or often at 2 years, a co-primary outcome with relapse suppression and decreasing disability. Now, how do you define disability? Basically, I simplistically think about it as sustained worsening on the neurological exam. Worsening on the neurological exam and sustained over time. That's a very important concept because anybody that deals with MS, particularly relapsing MS, understands the good day, bad day phenomenon. It is a very common finding if I evaluate a relapsing patient and I find them a little bit weak in their legs, and gosh, they didn't have that before, and I'm concerned that their neurological exam is worsened, okay, I may have them come back in a couple of weeks and that's gone. It's fine. It's disappeared. Their leg strength has come back to normal. That was not a true disability. It was not sustained. It was likely a reflection of the good day, bad day phenomenon. MS patients with their lesion load, their injury load, if you examine them at the end of the day or when they've done a lot of activity, their exam may not be as good as when you're examining them when they're very fresh. So this concept, particularly in relapsing MS, and we'll point it out, of sustained documentation of sustained worsening on the neurological exam is a very important one. And I think it's very important to really differentiate disability from progression. You don't see this done very much because people talk about, quote, disability progression. I don't think, this is my personal belief, you should be using that term in a relapsing trial. I don't like to use the term progression at all in a relapsing trial because I am going to distinguish disability from progression. Disability is sustained worsening on the neurological exam. That can occur in a relapsing patient. That can occur in a progressive patient. However, in a progressive population, sustained worsening on the neurological exam typically reflects progression of the disease, the neurodegenerative stage, the slow worsening. and that's by and large irreversible. So if you're talking about a progressive MS study, you can indeed refer to progression and mean slow worsening. That doesn't hold in a relapsing population. They're not gradually worsening. They can't be. By definition, if they're relapsing, they can't be gradually worsening. So we're really talking about sustained disability reflecting poor recovery from attacks in the relapsing population, whereas worsening on the exam progression reflects slow deterioration, neurodegeneration in the progressive population. So I don't like to use the term slowing of progression in relapsing MS. I'd rather preserve that strictly for progressive MS populations. Now we know that in the relapsing population, the exam can fluctuate day to day, will be worse with a relapse, but there's often good recovery from relapse. So you examine the patient in a relapse, their neurological exam is worse, but you examine them months later and it's much better. Sustained worsening on the neurological exam is really the meaningful concept, and that's why all the disability evaluations require sustained over some months. And the longer it's sustained, the more likely it is to stay, to be valid. Classically, sustained worsening on the neurological exam is over 3 months, but if you do it over 6 months, that's more valid. Your percentage of patient population that will meet a sustained worsening over 6 months is smaller. So you're looking at a smaller fraction of the population that will meet that outcome, but it's even more valid. That's not a lengthy sustained worsening like 6 months is not so necessary if you're dealing with a progressive population, because their worsening is going to be in the setting of reflecting their neurodegenerative progressive disease and is much less likely to reverse. Now, what are the disability measures? The disability measures. The Kurtzky Expanded Disability Status Scale, the EDSS, remains our gold standard. Sustained worsening on the EDSS of 1 point, is the classic disability measure, but there are others. The MS Functional Composite, or MSFC, we'll talk about that briefly. The MS Severity Score, MSSS. Cognitive status, I'll only briefly mention that because we have a talk this morning on that. Transition to progressive disease can be considered a disability measure. And then I'll briefly mention the concept of mortality rate, an interesting outcome, freedom from disease activity. Another interesting outcome, sustained improvement, decreased disability, sustained improvement on something like the EDSS. And then finally, it would be fair to say that a disability measure is MS-related quality of life outcomes. I'm not going to mention that further, but that could fall under the aegis of a disability measure. Now, the EDSS is key, but this is a very tarnished gold standard. The EDSS is the most widely validated, used, and accepted as part of all pivotal trials. This is the key disability measure. Sustained worsening on the EDSS, classically 1 point. That may be less in the higher EDSS range. Now, the EDSS is a 0 to 10 scale. 0, perfect, 10, you're dead. It reflects the neurological exam, so there are functional systems that look at motor, sensory, cerebellar, brainstem, visual, bladder, bowel, cognitive, and other functional systems, as well as ambulation, the ability to walk, how well you walk, whether you need an assisted device is key to determining your EDSS score. This is a very tarnished gold standard. There are significant weaknesses. Okay. First of all, it's an ordinal scale with 19 disease steps. That's not how you get worse on the neurological exam. You don't get worse in an ordinal manner. It is heavily weighted by ambulation. If you can walk 500 meters without resting, without an assistive device, your EDSS is 4. It can't be any higher than that if you can walk 500 meters. If you can walk 100 meters but you really need a unilateral assistive device, then you're 6. If you can only walk 20 meters bilaterally, a bilateral assistive device, you're 6.5. If you can't walk any marginal distance, then you're an EDSS 7. So that whole middle portion of the EDSS is very dependent on the ability to walk, how far you can walk without resting, how far you can walk unaided or whether you need an assisted device. It really doesn't assess cognition very well at all, and you could also critique its assessment of vision. And there's very high intra-rater as well as inter-rater variability. If you're using the EDSS, and that's a key point, you really need training sessions. You really need spelled out how to interpret, how to grade the various functional scales and how to come up with a number, because people may have somewhat different ideas about that. This has been documented, intra and intra-rater variability that can really screw up your EDSS results. And at the low end, very minor changes can affect the EDSS. At the high end, it typically takes much more major changes. So there are a lot of deficits in this. It's really a bimodal distribution rather than a Gaussian. MS patients really lump at the low end or at the higher end. MS patients don't stay very long at EDSS 4 to 5.5. They really don't. And without knowing anything else about the patient, I can say if a patient has a low EDSS, they're probably relapsing. If the patient has a high EDSS, they're probably progressive. You really see the population split out, low EDSS and high EDSS, really a bimodal distribution. Now, these were interesting studies that looked at EDSS reliability in relapsing populations. They really do give us some pause for thought. In this first study, they took 2 placebo arms that involved 313 relapsing patients from a glatiramer acetate trial and a sub-Q interferon beta-1a trial. And they looked at the relapsing patients that had sustained increase, worsening on their EDSS for 3 months. Well, it turned out of those relapsing patients in the placebo arm that showed sustained worsening on their EDSS, they reached disability outcome. Only half of them showed that persistent to 2 years. The others cleared up. The EDSS improved. Okay? After 3 months, they improved. By 2 years, that disability had disappeared. And even if you looked at 6-month persistence, which is a more rigorous, they had worsened on the EDSS consistently over 6 months, only 2/3 of them maintained that out to 2 years. The other 1/3 got better. Their EDSS improved. This is a known issue when you're looking at a relapsing population. In this other study that looked at close to 1,200 patients that had sustained EDSS worsening, when they looked at the relapsing population, CIS is, of course, a first relapse, clinically isolated syndrome, sustained EDSS worsening for 3 months, 25% of that cohort had disappeared, had cleared up, had improved on the EDSS within 2 years. 40% had recovered within 5 years. Over 50% had recovered within 7 years. They had lost the disability. And when you even did 6 months sustained worsening on the EDSS in this relapsing population, 25% had lost that worsening by 3 years and 40% had lost it by 7 years. So the EDSS changes can be quite variable in relapsing MS, and we just need to accept that. That is an issue. What about the MS functional composite? This is a 3-component composite, 25-foot time walk, 9-hole peg test to evaluate the upper extremities, and a cognitive test, the PASAT, Paced Auditory Serial Addition Test, which is an awful test, in my opinion. This is really heavily weighted by the 25-foot time walk, but it has these 3 components. And you calculate a z-score based on a reference population, and then you look at the outcome. Now, this has been documented to be more sensitive than the EDSS. It was actually designed by committee a number of years ago to replace the EDSS. That never happened. The MS functional composite never was accepted to replace the EDSS as a primary disability outcome. They have reconvened the panel to readdress this issue, to tweak the MS functional composite, to have another go at replacing the EDSS. And we'll see what happens in the next couple of years. They're going to try to use the MS functional composite as a replacement, as a better EDSS. They're planning on adding likely a vision assessment that will look at low contrast acuity, which is way more sensitive than the typical vision test. They need a better cognitive measure than the PASAT, which is a terrible test for a bunch of reasons. And it may be that this will replace the EDSS finally in the next few years. We shall see. What about the MS severity score? This is an interesting concept. It looks at the EDSS along with MS disease duration. So just think about it. If you have an MS patient that reaches an EDSS of 6, but they do it in 2 years, versus an MS patient who reaches an EDSS of 6 in 20 years, that's a different disability level. One was reaching disability very quickly. The other was reaching it very slowly. The MSSS takes account for that. It really does a decile of EDSS within a range of similar disease duration. Now, to calculate this, you have to have MS at least 1 year. This is really an analysis that you can use on a population-based basis and do a cross-sectional analysis to get a better handle on the severity of MS. So you can look at MS patients entering a trial and do an MSSS and say this is a much more active group than the patients that entered another trial. But it's really not helpful for an individual patient. And interesting analyses have been done. I think the MSSS was used to try to define benign relapsing MS, an EDSS of less than 2, 30 years disease duration. That was 4.5% of the population. And you can use the same thing to determine a malignant percentage. But I don't see this replacing the EDSS or the MS functional composite. Briefly, you're going to hear a talk about cognition. This is just a recognition that there are some patients who really get worse principally on cognitive parameters, and this is typically in longer disease duration with heavier cortical lesion load. There isn't really an accepted best measure. We'll be hearing more about this, I'm sure. There tends to be a low rate early, and I really can't see cognitive status as being a primary disability measure, except in very pre-selected patients, long-term trials or very specific trials. But we'll hear more this morning about this important outcome. I might say that the most important disability outcome is this one, transition to progressive MS. The natural history of untreated MS is to start out as relapsing and then move to secondary progressive disease, and every progressive patient becomes disabled. We know that. It's a critical question whether our current anti-inflammatory disease-modifying therapies used early in relapsing MS, which is where we're using them now, can prevent that relapsing MS from ultimately moving to a progressive stage of the disease. We don't know that answer yet. This is a very, very meaningful outcome, but not practical as an outcome in short-term trials. This is long-term. This is long-term, population-based, critical study. Can we actually prevent transition to progressive disease? But that's going to be a long-term outcome. Mortality rates. Interesting. Recent emphasis on death rates in MS. We know that we don't think of MS as a killing disease, but if you look at MS populations, they don't live as long as control populations, particularly if you have greater disability. And there's some data now suggesting that institution of disease-modifying therapies may lower long-term mortality rates. But these are long-term studies. They're 15 years plus, and again, not a practical disability outcome for shorter-term trials. Freedom from disease activity. In a way, it's not fair for me to mention this because it throws in an MRI measure. It's not strictly clinical, but I'm very intrigued by this outcome measure. It's a fairly strict one, and it's a yes or no type of answer. It's looking at saying in a clinical trial, your outcome is no sustained disability, plus not a single relapse, plus not a single new MRI lesion occurring. As far as we can tell on clinical and MRI disease activity, no evidence of any damage. Now, obviously, it doesn't speak to actually looking at whether there's microscopic injury, but this is a very rigid measure. It's an appealing measure as we get multiple therapeutic options, as we're looking for better and better disease control. Dare I say a cure? We're not there yet, of course, but this is your optimum. You'd want no disease activity. This is a very rigorous outcome. It's been proposed. It has not yet been used as a primary outcome, but they're doing analyses looking at this in modern trials. I think it's a very intriguing disability outcome. This is the flip side of the coin. If there are patients that show sustained disability, sustained worsening, are there populations that show sustained improvement on therapy? Can you show sustained decrease in the EDSS on a treatment? Now, this is extremely intriguing. It's kind of the reverse of the typical disability analysis. It's been proposed as a novel disability outcome. It hasn't been used yet. I think preliminary forays are looking at trials and looking at this particular outcome, and we'll see where it goes. So in summary, disability remains the most significant clinical outcome in MS trials. Sustained EDSS worsening, classically by a point, over 3 months, sometimes 6 months, remains the standard disability measure, but the defects of the EDSS are well recognized, and right now it's looking like there's a good possibility in the next few years that a modified MS functional composite may turn out to be the EDSS replacement after all these years. Thank you. So we are going to move on to our second talk in this evaluation of clinical trials outcomes, and we're going to look at MRI outcomes. And we have Bob Zavadinoff, who you all know very well. I don't need to introduce him to talk about that.
Thank you, Patricia. I think you did really give a wonderful talk, and clearly the disability-related outcomes have to be considered when we are doing our trials. What I'm going to try to do now is try to give you similar talk from MRI perspective, because what we heard in all these days is that there are clearly measures of interest for understanding and studying CCSVI, but most of these measures are not what we are doing in clinical trials. So actually I missed my disclosure for some reason, but I think that I presented it a number of times during the past days. I received in relation to this talk both grants and consultant fees from most of pharmaceutical industries in MS field. Now, what clearly is been emerging is that beyond the MS lesions in the white matter that are clearly easily recognized by classic MRI techniques, there are lesions also that cannot be recognized, especially between gray and white, and newer techniques like 3 Tesla MRI, three-dimensional flare, and double inversion recovery, I'm going to show you these sequences, are able to show more of these lesions. Now, one of the hottest arguments in multiple sclerosis beyond the CCSVI at the moment is the cortical pathology. It has been recognized that in patients from MS, with MS, there are vast areas of demyelination in a third layer of the cortex. These lesions represent more than 60% of the total lesion volume in patients with MS. So imagine that we do not see on MRI about 60% of the lesion volume. Now, one of the main reasons why we don't see these lesions on MRI is because they have very little water inflammation and they cannot change the relaxation time. So neither one MRI technique is actually suitable for visualizing those lesions. Until very recently, it was believed that this is a mid to late stage phenomenon in MS. However, we are learning from recent studies, mainly by the Mayo Clinic. One of them I would definitely suggest you to read, published last month in New England Journal of Medicine by Dr. Lucchinetti, that there is a transitional inflammation in a cortex accompanied with huge meningeal inflammation. So at the moment it's very unclear if the meningeal inflammation is the first point of the disease and how these lesions get so inflammatory and why so quickly this inflammation disappears. Nobody knows really how these lesions are created. Some studies found that these B-cell follicles in the meninges are very rich with Epstein-Barr virus, but some did not. And so these chemotactic factors from these follicles are probably responsible to create this demyelination. If you read even more carefully this paper, there is a whole hypothesis put forward that through the CSF spaces, this cortical inflammation is taking the response to the white matter and deep gray matter and starting the process there when we begin to see the first lesions. Now, obviously, I'm extremely interested in this topic, also in relation to CCSVI, because we believe that Epstein-Barr virus and CCSVI may be very well connected, and that possible stasis, even small one, in the superior sagittal sinus due to the jugular outflow problems may lead to possibly higher antigenicity of all these viruses and other germs that have been shown to create higher susceptibility as well as severity for MS. So what is happening, it's very clear. By the way, these lesions that I'm showing as iron, you heard a lot in these days, and we have evidence that they are present very early on in the disease. So what's happening? You are developing new lesions, you are beginning to develop cortical and especially deep gray matter atrophy from very early on. Over time, these lesions get smaller, not because they are improving, but because the ventricles are so much enlarging over time. And clearly there are positive processes that are trying to limit the damage. So now I will go much quicker through the slides. So what are the MRI inflammatory features in MS? These are gut-enhancing lesions and T2 lesions. Each of those has a pathological substrate that's ranging from the simple blood-brain barrier disruption to the axonal loss. And we can measure that by so many techniques. So what we do in clinical trials, we measure how many of these hyperintensities are seen at every time point on T1 weighted post-contrast scan. So T1 weighted post-contrast scan is kind of essential for doing clinical trials in MS. Now, it has been shown that MS treatments, especially the interferons, these are early 90s, are capable to bring that enhancement down by 80%. Even more, Tysabri, another very important drug in MS, was capable to bring this down by 92% at year 1 and at year 2. So very, very profound decrease of inflammation. Now, even in recent study with Copaxone, it has been shown that this effect can be in 7 to 9 months between 65 to 75% with 20 or 40 milligrams. Clearly, we can see more gut-enhancing lesions by applying some strategies. Is this practical in clinical routine? No. But just so you understand, giving more higher dose of gadolinium will show more lesions, delaying the scan by, instead of 5 minutes, which is standard, to 10, 15, clearly can show more lesions. There are even new contrast agents that are based on iron oxide and that can find macrophage and microglia activity. So not the concept of the blood-brain barrier disruption is under really intensive research in MS, and it seems that it's not inflammation, everything which just creates the blood-brain barrier disruption, but also microglia and macrophage activity is playing a very important role. T2 lesions are situated in specific areas of the brain, typical dorsal fingers. They are always perivenular. And you heard so much about this in these days. They are usually located in the periventricular part, in the corpus callosum, in the brainstem, and in the cerebellum, as well as in the spinal cord, as you can see here. In number of different trials, it has been shown that disease-modifying treatment, in this case Rebif, is able to bring down this T2 lesion volume accumulation in comparison to placebo with a range of 0 to maximum 10% with Tysabri over 2 years. There are clearly strategies that can improve sensitivity and specificity in T2 lesion detection. If you use thinner slices, if you use different other sequences that I'm going to show you, or 3 Tesla MRI. Now, just by doing three-dimensional FLAIR, you are going to see more lesions than with the two-dimensional FLAIR. If you do 3D FLAIR enhanced, that is a sequence we recently published, you are going to see even much more lesions than you see with the 3D FLAIR or with the 2D FLAIR. Our sequence is based on a recognition of the best optimum contrast between recognition of lesions and the surrounding white or gray matter. That's why, as you can see, to get on FLAIR such a distinction between gray and white, we are testing this sequence against double inversion recovery at the moment. But double inversion recovery really played a huge role in the last 5 years to detect this amount of cortical pathology. And you have probably had over 50 studies published on DIR. So what's DIR doing? DIR is not just suppressing the CSF, but it's also suppressing the white matter. Even validation of the now available guidelines came out recently, and although specificity of this technique for finding cortical lesion is high, sensitivity is low, 18%. So histopathological studies are showing that you are going to miss 82% of these subpia lesions that I showed you before. DIR is also superb in detecting lesions in the fossa posterior. Clearly, if we scan patients on 3 Tesla, you are going to find out more of these smaller lesions than with 1.5. And this is just to compare 3 Tesla versus 1.5. What is in yellow-orange are more lesions, significantly more lesions detected with 3 Tesla. Another outcome are T1 hypointense black holes. Those lesions on pre-contrast T1 scan that look hypointense have greater tissue damage than those who are hyperintense on T2 or positive on GAD. And they correlate better with disability than inflammatory lesion measures. It has been many years ago shown that clearly the amount of loss of axonal density is proportional to the hypointensity of these lesions. One of the first drugs to show that it can decrease accumulation of these black holes was Copaxone, and now this is clearly an outcome in many clinical trials, like with Tysabri. Beyond the lesions, we look on another measure that's extremely important for predicting disability, and this is brain atrophy. Brain atrophy can be measured over whole brain, in just gray matter, white matter. You can do it in the deep gray matter structures, you can do it in the cortex, or you can do it by measuring central atrophy. It has been shown in one of my really first studies that change in brain atrophy is a great predictor of cognitive disability in patients with MS. More recently, it has been shown that gray matter atrophy is progressing much more rapidly than white matter, and it's principally driving disability. Current research is ongoing to understand whether development of gray matter atrophy in the subcortical structures is more important for development of disability very early on and conversion to clinically definite MS than in the cortex. All of the drugs have been tested on change of brain atrophy over time. And those drugs that did not show phenomenal or great effect are kind of considered now to be maybe less effective on suppressing disability. There is a phase when patients who are treated are losing more brain than those who are not because you are decreasing inflammation. That's called pseudoatrophy. That's exactly what we saw with Professor Zamboni in this very small trial we did on CCSVI over 1 year. We saw that patients who have been immediately treated with endovascular treatment lost 1.6% in the 6 months, but those who have been treated, who have been not treated but just on their standard modulating treatment lost 0.8% in 6 months. And so this is published now, and so we need, when we do brain atrophy study, we need also to consider same phenomenon, whether it's a change in blood volume flow or it's a change related to inflammation. It has to be proven. That's why we are doing studies to understand what the endovascular treatment for MS may do or may not. You need to understand that like we like to see improvement on EDSS, we like also to see with these treatments myelin and axonal repair, and that's why we are doing techniques that can monitor this repair. Mainly those are magnetization transfer, diffusion, tensor imaging, myelin water fraction. By simple measuring the MTR in the black hole or on a lesion level, you are able to see whether this lesion is improving in magnetization transfer or not. Magnetization transfer is a very simple measure that measures how much protons are binded to the macromolecules. If there is a demyelination, amount of these bounded protons decreases, or if there is a remyelination, increases. But this is not exactly true, because also resolution of edema in short term may increase the MTR, and it's not 100% specific for myelin. We are moving to new ways to detect D and remyelination in the brain. This is a recently published study of our group on effect of Tysabri and Avonex on magnetization transfer on a voxel-wise basis. What you see in green are areas of remyelination or increase of the MTR, and as red, areas of demyelination. So as you can see, which is very important, these two processes are not happening just in the lesions, but they are happening also outside of the lesion. So there is a lot of activity that might be related to this subpial demyelination. Another measure that's been used in clinical trials is spectroscopy, and it's very important for understanding axonal repair, especially measuring this N-acetyl aspartate. In treatment with GEA, it has been proven that in clinically isolated syndrome patients, those who have been on Copaxone do better on NIA than those who are not. So we have a variety of measures that have been used in clinical trials. The classic ones that I think should be done in every trial with CCSVI are T1 post-contrast, T2, T1 black holes, and brain atrophy. This is a must to be done in every clinical trial to understand, can endovascular treatment for CCSVI be disease modifying? And that's clearly something that we are investigating and that we investigated also with Professor Zamboni. And although the numbers were extremely small and non-significant, we saw some trend for decrease in T2 lesion volume in those who have immediately treated respect to those who have been delayed. But only bigger studies are going to show whether this is true, because as I mentioned a number of times, and also you heard from Dr. Burke, clearly we need to understand, is CCSVI endovascular treatment potentially disease modifying, or is going to only affect quality of life and symptom management? And this has to be established and will be established very soon. So you can see I'm not going to enter in particular treatments, but all treatments have effect on T1, T2, and black holes, some less or more on other measures. We are even not able to do all these measures in clinical trials because they are time-consuming. And so what I would add, clearly we are interested here to measure the flow, to measure the things related to the flow, including iron, perfusion of the brain, CSF flow, and other things. But we will need to find a combination between doing classical MRI outcomes that can prove whether this disease, whether this treatment is disease modifying, as well as trying to understand pathophysiology of the events that are following treatment by understanding how the perfusion of the brain is changing, can iron load deposition be affected, etc., etc., etc. So obviously it's a long, long walk in front of us to accomplish that. And I think that when you begin to think your trial, you need to take these MRI measures in consideration. Thank you. Okay, it's my pleasure, although I'm not a chairman, but I will introduce a great friend and a scientist who really invented how we measure cognitive disability and progression in, no? It's, you switched? Okay, it's then my distinct pleasure to introduce Bianca Weinstock-Guttman, another friend, without whom our CCSVI research would not be possible. Somebody who, one of not many neurologists who decided that this is a valid idea that should be pursued on ethical and science research basis, and we embarked on so many studies over the last 3 years, and I'm really thankful to her.
Thank you, Robert, and thank you for inviting me here. Actually, I was taught that it would be interesting to provide this talk related to the necessary interdisciplinary approach to try to really get to the bottom of this CCSVI topic, treatment, and relation primarily with multiple sclerosis. I did consider that actually going over our step-by-step research that we did for the last 4 years can actually give us a very nice and well understandable importance of interdisciplinary approach, bringing specialists from different disciplines to better understand, as I said, the role of CCSVI, the implication of CCSVI not only in MS, in general on health and disease, and sure enough, how should we approach as a therapeutic intervention, and maybe one time prevention. So the way how we started, I think is very important to tell the research. After having the pleasure to start with Professor Zamboni the very initial trial, we started our large CTVD trial looking for prevalence of the CCSVI defined issue exactly per Professor Zamboni on a large group of patients, MS, healthy controls, and other diseases. And further on, we try to already predefine, besides the prevalence, we did consider to go further and understand all the elements that we know are important for MS. And after then to determine if this, and I will go over these elements, including genetic, environmental, all the elements that we know as MSologists that are important, and after then to try to apply what is the relation with CCSVI on the same elements we know are important for MS. Second one is really how the best will be to identify the best way of visualization of the hemodynamic, the structure problem of the venous. Clear enough for this we need a lot of help, and all the neuroradiologists, vascular specialists were involved in developing our new measure to learn what is CCSVI and how to really correlate with the pathological findings. And the third one is clearly intervention and therapies, that we have a very strong recommendation to be performed only under auspices of research and following the data. And sure enough, I think after all the data we have today for open studies, there is the time clearly to recommend a double-blind study that I heard that Professor Zamboni already received a large amount. We do have, and I know that Dr. Siddiq already presented, our pilot study on this double-blind. And the future will bring up further, hopefully, much better methods to determine and to learn about CCSVI, their role. And again, for all this point, we have to bring neurologists, MS specialists, immunologists, geneticists, specialists in vascular, in neuroimaging, physicists, and all the disciplines to try to have a good answer. So, as we're looking for the two phases today, right? Maybe we'll have more and more phases on multiple sclerosis. Is the autoimmune part on the right. The left side is the vascular possible relation, not only on causing, but possible interfering with the progression of the disease. This is actually what we had at this time, much more from our data. Clearly, from the MS standpoint, we need, as beside the neurologist or our immunologist, and geneticists that are helping us to understand the risk for MS, the way how to prevent it, hopefully, and how to treat it, prevent the progression of the disease. And the left side that we have is the vascular part, the CCSVI, and clearly will need help from the vascular people, from the radiologists, physicists, and try further on to better understand the role of CCSVI in MS and other diseases. So clearly, as we started first, we look on the CCSVI prevalence in multiple sclerosis. And as mentioned before, we already had, and I have to really acknowledge Dr. Zivadinov for his, very scientific consideration from the get-go, not only on the initial steps of a disease, but providing from the get-go before starting the study. So to know that we will receive from the CTVD patients, large initially was 500, we're going over now to have almost 1,200, to obtain all the additional data that will be so helpful to understand the relation of CCSVI and MS. And these are a questionnaire of epidemiological questionnaire about infections, about diet, smoking, and sure enough, we also have our lab that Professor Ramanathan is the director of, in which we are able to perform genetics, different immunological assessment. So all this were actually deposited and in our repository to try to have an answer, a much more exact answer on the relation and further on, hopefully, treatment. So the data probably already saw it. It was published last year in relation to the CTVD study, the prevalence study from Buffalo, in which we did have 499 patients. You remember that were a little bit different type of analysis, but we did find a 62% frequency in MS patient of CCSVI, again based on Professor Zamboni criteria, while in healthy controls we also find 25%, and in a very early patient 42%, but also in the other neurological diseases we had a pretty high percentage, 45% of cases having CCSVI. We have to, and we clearly provide this information in the publication, that most of these other neurological diseases at this time in the first phase 1 were inflammatory diseases. The patient that biased came to see me, and there are, patients with other autoimmune problems. And possibly this could be a factor why the percentage was much higher. The number of the neurodegenerative diseases was lower on this, but within the next phase 2 trial, we try to extend this group of patients to learn more about CCSVI and other diseases. Trying again to learn more about this data, we did find that there is a clear correlation, besides that having a higher percentage frequency of CCSVI in an MS, also in progressive patient. So the progressive stage of the disease was clearly significantly higher association than the relapsing stage. This is a cross-sectional. We did not follow a patient on the relapsing stage with CCSVI if this has a higher chance to become progressive or not. We did not find if a patient didn't have CCSVI and developed CCSVI again. This could be only explained by prospective studies. Looking on element that is very important, we know MS has a part of genetic of familiar, around 17–20%. We did not see any relation on the familiarity, on the familiar history of MS within this group. So the data that we showed, and again we had involved on this data besides the neurologist and the MRI people as well, and I think Robert provided this data already, and the geneticist immunologist further. Again, what we said, we saw MS patient MS is associated with higher risk for CCSVI and with progressive disease. Now, again, we are all the time faced with this, trying to explain when we find an association in our data, what is the relation really to the causality. Association much easier to prove than causality. So we have to go for the next steps to try to prove, yes, indeed, this element that we found that's associated is really interfering with the disease. Disease as onset or disease as progression. There are multiple elements that we have to study and may interfere with MS. So as we saw, at least even looking only on our data, is that many patients with CCSVI did not have MS, right? So 38% or 40% depends on a different type of analysis. So that was one of our findings. Many MS patients do have really CCSVI. We see higher association. But also healthy controls and other diseases that do not have MS have also CCSVI. So it's clearly much more than MS, CCSVI, it's CCSVI and probably disease. So clearly CCSVI is not necessary nor sufficient to have MS, but again we did find this progressive relation to the progressive. We have a paper submitted in press and trying to see if really the disability, as you heard so nicely from Dr. Coyle, is disability related to EDS, disability related to CCSVI, and we didn't find this. So when we look on the patients with and without CCSVI, we didn't see much effect on the disability on the EDSS scale. Was a trend for this MS severity score, but was only a trend. However, the progression stage was associated. Now, and as also Professor Coy said, and so on, we really do not know exactly what's happening on this switching to progression. And we can say that there was switch only retrospectively, not prospectively, not easy. So this is the difficulty, but we know that something happens when the patient becomes from relapsing and begin progressive. Did they finish their, their reserves? There are additional processes. We don't see so much inflammation. Is this related to CCSVI? How actually, if this, at the moment we only show the association, how actually this is related from the CCSVI to progression of the disease? Probably takes a very long time. If we saw that it's more than 15 years, again, with no medication, we start to see the progression. It's a long term, so we should try to find an answer from MRI, from the additional, specialists, understanding not only specialists on MS, as I said, but also the specialists from the vascular part to determine the severity of different, hemodynamics and so on, to better understand why. Or I understand our very good presentation previously presented from the inflammatory area of the endothelial, from the venous part. So there are so many areas that can give us a hint to better understand the relation, and sure enough, we need all these specialists to get involved on better understanding the CCSVI. This is the usual picture we like in our multiple sclerosis pathogenesis and triggers. We know that we have a genetic predisposition, and we know they have environmental. And from the three environmental part, they're most strongest and come up. They're the EBV infection primarily. We see mononucleosis, so the clinical infection with EBV, usually in teenager, vitamin D, and smoking. So what will be the next way to go is to try to see the genetics, right? The genetics, we don't have one genes, right? The HLA is coming and coming all the time as the strongest related genetic predisposition for multiple sclerosis. But usually the HLA-1501, right, that's seen with multiple sclerosis, is between 50 and 60%. But in normal population, meaning the population that doesn't have MS, 30%. So again, there is a certain association, but it's not clear-cut required. There are MS patients with no HLA-1501, and there are also normal, healthy subjects that do have the HLA. So the next step was to, with the help of, again, our geneticist and friend, Dr. Ramanathan, to look on this HLA status on our patient, yes, no, CCSVI. And we could not find a correlate. So the HLA, highly correlated with multiple sclerosis, did not have any relation to yes, no CCSVI. Now, next step, we looked on, and this was very interesting work that Robert looked on it, and very logical. Let's look on the other risk factor, as we said, smoking and ABV and mononucleosis primarily. The ABV levels, we still have to work on it, but mononucleosis history, relation to the CCSVI presence in healthy control. And this paper was recently published in PLOS. The interesting finding is yes. The patients with having CCSVI, not the patient, the subjects, healthy controls that came in on our CTVD study did have a higher infectious mononucleosis, the one that had the CCSVI. They did smoke, and they did have a certain mild heart disease, because the really severe cardiovascular disease was a exclusion criteria to get in the CTVD study. So two factors that are known as environmental factors to develop MS, we see them here as risk factor for CCSVI and healthy controls. Again, the importance that we did look on all this questionnaire we have our geneticists, we have our statistician, all this important scientists from different departments and so on have to be involved to learn more on the CCSVI and the relation to the pathology, disease, and MS. And this is a study that I understand this was further developed and presented during the seminar, is the presence of the reflux and the MRI findings only with no relation to white spots, the T2 hyperintensity that we see in MS, we can see also as an aging process. And this was a very nice study that was actually published part on Annals and part before in ultrasound medicine, that patients or individuals that have a jugular reflux, they do have more T2 lesion in the brain. What is the exactly, how can you link this together? It will take longer time. It will take, MRI specialists, will take the vascular specialists to try to determine this, but they're clearly coming more and more that there is certain science link between the CCSVI and in general pathology, and not only multiple sclerosis, but again, if inflammation milieu interfering much more with this venous abnormality, probably is what we are dealing with. The next step is really how to diagnose CCSVI, and I heard that there were a lot of discussion on this, and there should be a discussion on this. It's how to, and this is again on the vascular specialist, on the physicist, what is the best way to evaluate the abnormality, the structural abnormalities, and the hemodynamic abnormalities, their impact on the disease. But again, for all this visualization and so on, we need the help and to work together. And that's our really lucky thing that in Buffalo we have all this together, and started sure with Professor Zamboni that taught us at the beginning how to do the Doppler ultrasound. This is again one evaluation, one type is really not enough, and all the data that we have, and Robert added on so many presentation and already paper out showing that we do need multimodal evaluation, the dynamic, the structural, ultrasound, Doppler, MRI, MRVs, that further on was really proven by intra-invasive evaluation, intraluminal, intravascular, with the IVUS, with the venography. So sure enough, we would like to have all the data non-invasive, the evaluation to be non-invasive, but again, we have to prove the correlate of the validity of the non-invasive measures. And again, looking for physicists, looking for all the specialists, and ultrasound are so important to share the data, and we are really open to get this and improve our assessment. And this again is a recent paper out. I think the Dolly also presented this on the sensitivity specificity for different hemodynamic problems, structural problems, using different methods. So it was a multimodal evaluation determining which one are the best for the intraluminar, for the structural, and for example, for the collaterals. So I won't go on this more. The next one is the therapeutics. Again, we had a very early small study with Professor Zamboni as interventional that already Dr. Zivadinov alluded to and was already published. And the way how we still try to control it is by delaying with 6 months between the two groups. So clearly the very first comparison for us was let's do a 6 months difference. But the next steps that we are doing, and Dr. Siddiqui had a great presentation, I understand, it's great. On an ongoing study, we have controlled the premise study in which we really looking, as we are now in the phase 2 trial, we had the first phase 1, looking for the safety of the venoplasty, but the second one is really double-blind. The patients are identified by the neurologist. First with MS, second they have the ultrasound Doppler, so this is the second group. The third are going to have evaluation with the neuro interventionist for the pre-op intervention, and after then followed by us. Again, the clear-cut, very interdisciplinary team required to perform these studies, testing and monitoring the results and eventually, step by step improving it. Because I think that, if we have preliminary data, step by step, as we see outcome measure, which one will be more sensitive to be added on this very difficult type 2, design study and perform, we have, I think, at the moment, try to bring up the most sensitive we have, and maybe even later, certain things that may change, maybe, introduced on this study to really learn the role of CCSVI in MS specific at this time, and later on probably in other diseases. So this is the big multiple disciplinary that we, as already mentioned, for the study. We are a large team involved in it. The study is almost done as enrollment. We still need one patient. The 19 was done, so the 20 is already there. So we're waiting, and hopefully we'll have an answer within 6 months from now. So the next focus for our Buffalo CCSVI, we really will go further. We want to have an answer, and we'll try to see the relation CCSVI-MS, CCSVI with other diseases, and help. Maybe people may be able to keep going with this longer time. Why versus whether they're not, and clearly how to identify this as more sensitive with non-invasive. Again, physicists, neuroradiologists, interventionists, any better possibility to evaluate would be good to provide and implement with the large ongoing studies and not the small ones. And that is what really, I think, hurt it so much for the small study provided with no, even clearly non-significance at all, and still accepted so well into the large audience. So for people that are really looking at, even as trying to determine, we don't have a clear-cut answer. Provide the best tools from the best scientific people here, bring it together and get an answer, and not stay on this very small, independent, non-informative, but only damaging the data. So this is all our next phase 2 CTVD study, in which we did the same thing, evaluation of our patients. We have samples of the blood. We have a wonderful cross-sectional data. MS patients on different ages, including the pediatric. We have initially we had only 5. Now we're going to have much larger, up to 30, hopefully more. CIS very early on. RIS patients that do not even have MS per clinical, but only per MRI. So we're trying to get much more data on this to get on a cross-sectional as information we can without to need longitudinal, or there at the end longitudinal data will be the most important to see the role in MS. Again, we look on all the genetics, inflammatory markers. We very much would like to collaborate with people that are so much involved in the endothelial when we started inflammatory process, to try to bring all the pieces together, and for this we need all these specialists from these different areas. So that is all my talk. Really we need a corroborative together research between neurologists, vascular specialists, physicists, all the scientists that hopefully will be interested on this element, because CCSVI, it appears, is not only MS, it's much more, it's something related to health or disease, and at the moment we have, I think, enough data to bring on much more people to be interested in it and have an answer. Thank you very much. We really thanks for all our patients and for everyone that really helped us so much. We, as really disclosure, there was only very funds, provided to BNAC to go on, but most of the study was really unfunded, and only with the power of our willingness to know it went further. Thank you very much. And now I can introduce Dr. Ralph Benedict, that is really the authority in cognitive assessment in multiple sclerosis patients. He's a great friend. He's very strict with our patients and with ourselves, but he is the He is the scientist that put together the best measures for cognition, going from 4 hours that would be awful for any of us, think about MS patients that have problems, and trying to make it smaller and shorter, but still maintaining the meaningfulness. Thank you.
Thank you. Hello? Am I on? Thanks. It's a pleasure to be here. Cognition is an area that is increasingly important to MS patients. As they're doing better with other aspects of the disease with the advent of these disease-modifying therapies. More and more patients are coming into clinic concerned about how well they can think and how their decline in cognition may be influencing their ability to work and their quality of life. And further evidence of this interest, I think, are the so-called symptomatic therapies for cognition that we're seeing investigated in the literature. Medications that are targeted at cognitive impairment, such as donepezil, lisdexamfetamine, L-amphetamine. We've done 3 trials ourselves in Buffalo in this area. There hasn't been anything definitive yet, but there's quite a bit of interest in trying to remedy this problem. And so when we get to the topic of disease-modifying therapies and clinical trials, I agree with what Dr. Coyle stated, that I don't think cognition is ever going to be a primary endpoint, but it's certainly going to be an important secondary endpoint. And as we move further with the CCSVI efforts, I think it's going to be a very important thing to look at. So what I'd like to do in the next few minutes is to address these 2 objectives. What are the cognitive domains, the spheres of cognition that we need to pay most attention to? Can we really define those right now? And how well do the candidate tests that we may consider as outcomes meet criteria that are of importance to regulatory agencies, particularly the FDA? If our outcomes are not deemed by them to be valid, then we're really wasting our time because we're not going to be able to say much about any kind of indication for a therapy. So the issue of evaluating cognition in MS is an extremely complicated one clinically. It's an easy day for me when I see a patient with a stroke or Alzheimer's disease or Lewy body dementia. It's almost a day off compared to when we evaluate a patient with multiple sclerosis, because there are so many different things that may be affecting the patient, and any one of them may not even be present at all. Some patients are cognitively impaired, others are not, and the quality of the cognitive impairment can be pretty variable. Fortunately, over the last 20 years, there's been a tome of literature on this question. And we have consensus on the areas of cognition that are most important. Going back to Steve Rayo's seminal work in the 1990s, we learned then that the tests that emphasize processing speed and episodic memory are most important. And in a very large study, we replicated that same finding as we developed a battery called the Minimal Assessment of Cognitive Function in MS. And we found using that battery that we had the same quality of or profile of cognitive impairment in our patients, a slightly higher incidence of impairment because our sample was a clinical one rather than a volunteer one from Rayo. But this general profile where there's greater impairment on tests in these spheres has been replicated widely. And the 2 most common batteries, if you will, used in the literature these days are the brief repeatable neuropsychological battery from Rayo's work and the McFIMS that I just mentioned. This McFIMS battery is a consensus panel battery of tests identifying the most likely useful tests in these spheres of cognition listed here. And so in this study, we examined a sample of MS patients against controls and looked for the most sensitive tests comparing these two common batteries. And what we find is in the area of memory, verbal memory, two tests, the California Verbal Learning Test and the Selective Reminding Test, have relatively equal sensitivity with strong effects distinguishing the groups. In visual memory, a test that was developed in Buffalo, the BVMT, is most sensitive. And then finally, in the area of processing speed and working memory, simple digit modalities test is the most sensitive test. And in fact, the SDMT has shown to be most sensitive in many studies and is more sensitive than the PACEAD in our data and elsewhere. You'll recall that the PACEAD, the Pace Auditory Serial Addition Test, was a test mentioned by Dr. Coyle earlier. This is a test of auditory processing speed. It's very widely used. It's part of the MSFC, but it's very difficult for patients. It's difficult to administer. It's cumbersome, and it's even stressful. Patients often complain about having to take it, and so consequently there's quite a bit of interest in using something else, and I'll mention the idea of the SDMT and the MSFC in a moment. So what's important to regulatory agencies? Well, they've actually are starting to get it from a psychometric point of view. They have published documents like this one and stipulated that psychometrics such as reliability and validity are very important to the way they judge the results in the clinical trial. If you have an outcome measure that fails with these criteria, then the likelihood of getting an indication on the basis of that outcome is compromised. This document, you will note, is about patient-reported outcomes. And this has to do with quality of life measures, depression measures, and tests of that nature. This is not the same thing as cognition, although we would like it to be. It would be very simple, as all we had to do was to ask patients if they have any memory problems. And that would be the simplest thing, wouldn't it? And that was the idea that we had in developing this MS Neuropsychological Screening Questionnaire, or MSNQ. The development of the test went extremely well. We have very good reliabilities and good internal consistency in this measure. I can assure you that it is a very good test, a very good metric of what the patient thinks is wrong with them cognitively. Also, there's a caregiver or informant form of this, and it's equally valid for that purpose. Very good test, retest reliability metrics, and that's been replicated widely. It's also been translated into about 30 different languages. Very good. There's one problem. What patients say about their own cognition has almost no or little bearing on what they can actually do on more objective performance-based testing. What patients say about their own memory is much more strongly correlated with whether or not they are depressed. And this has been shown in about 12 different studies now. We're stuck with this. There's no way around it, and there's no way to screen for cognitive impairments with sufficient sensitivity and specificity by asking them. So we have to do testing. And so what should we do? Well, I would propose to you that this is simple digit modalities test is probably the best candidate that we have. This piece of paper, 8.5 by 11-inch sheet, is handed to the patient, and their job is to look at this key up here and then to say the numbers that should go with each symbol as rapidly as possible, reading down the page from left to right. So the patient says 1, 5, 2, etc. And they simply go as fast as they can for 90 seconds. The examiner has a sheet in their clipboard, and they simply write down the numbers the patient states. It's very quickly scored, and you're done. Less than 5 minutes. I've seen 2,000 MS patients. Never once has a patient ever complained about doing this. And you can't say that for the PACEAD, where patients complain about that frequently. So this is certainly a good candidate. So is it reliable, is a question. Well, we find that it is quite reliable in a number of different circumstances. In this study, patients came into the clinic every month and were administered the SDMT with a few other brief tests. And these are the mean values and the error bars and the reliability coefficients for the test-retest interval. And they're extremely high, as you will note. There's also very little learning in this, as you can see, over the monthly intervals, despite the fact that they're getting the same form of the SDMT on each occasion. So when the issue of PML became prominent in the natalizumab world some years ago, I was asked to help Biogen with the introduction of natalizumab study, which was a safety monitoring study, the idea of which was to screen for the possible incidence of PML before monthly infusions using some sort of brief test. And we thought about the SDMT and the MSNQ at that point, because PML presents very often with psychological or cognitive impairments. There were other screening measures, but when it came to the psychology and cognition, SDMT and MSNQ were good candidates. So we proceeded in that fashion. And I went to an investigator meeting and spent about 2 or 3 sessions with different people, giving them a brief introduction and training them how to do this test. Many, many different languages. You can see here many different countries. And I thought this will never work because I didn't have much time to train these people. I don't know who's going to be doing this. I don't know how good the translations are. And I thought this would be a disaster. But lo and behold, the reliability coefficients monthly were extremely high. And these are almost unbelievably high. You will note that there's more learning in this than in the last graph I showed you. There was some discussion as we wrote this up for publication about what that means, because this is sort of a quasi-experimental comparison between this data and the previous data on those patients that were getting conventional DMT therapies. It's been noted that patients often feel better on natalizumab. There's discussion about how one can really determine whether or not there is a cognitive effect with natalizumab, and I'll leave that to you for your own opinion. We were uncertain about it in our discussion of these data. At any rate, simple digital modalities test, surprisingly, for this little test, when you look at a whole battery of cognitive tests and compare it with MRI metrics, almost every single time SDMT shows to be the most robust correlate among these tests. And some of these correlates are quite high, as you will note. It's also the most sensitive test in these large batteries, time and time again. It almost never fails. What about its clinical relevance? This is what regulatory agencies are particularly interested in. So in this study, we looked at quality of life measures, self-reported quality of life, and whether or not patients had work disability. And using a hierarchical regression approach, we looked at many variables in all of these compartments or areas of clinical status, including EDSS, various disease features, cognition, etc. And what we found that with self-reported quality of life, how satisfied the people are, basically that was driven by measures of depression, whereas with vocational status, cognitive testing was the primary driver of that outcome. And here's simple digit modalities test, the first cognitive test to enter the regression model. Yet, we don't know much about incremental changes on SDMT, which is the new big issue with regulatory agencies. How do we know when a change on a metric becomes clinically meaningful? And so there is emphasis on establishing thresholds for meaningful change on an individual level. How do we define when someone becomes a responder? This is especially difficult for my area. It's bad enough when regulatory agencies are saying, well, how do I know that doing the 25-foot walk faster by a half a second. How do I know that that's clinically meaningful? And there are ways of trying to argue about that is clinically meaningful. But that's walking. What about simple? We all walk. We walk every day, but we don't walk around doing the simple digit modalities test, do we? I mean, that's just not very face valid. So this is a huge issue for cognitive outcome measures. We've begun to try to take some stabs at this problem, but we have more work to do. You will recall that Strata data showed a pretty consistent learning effect over the year on those monthly time intervals. So there were no PML cases in that study, but there were relapses. And so we retrospectively had a look at the cases where they were tested at about the same time they were having a clinical relapse and compared them to matched patients that had no relapse and were seen at the same time interval. And this is what those data look like. Here's 1 month time point, here's the next one, here is the relapse point, and you can see that there's a decrement on SDMT that to some extent rebounds. So, one anchor point, if you will, would be this degree of decline on the SDMT. And so we might argue that a 5% drop on SDMT is clinically meaningful because it's associated with a face valid, discernible, very plain, common man appreciated clinical event. Another similar approach would be to let's go back in time with a retrospective longitudinal data set and find a bunch of patients that were employed full-time at baseline, and now we look at them now and determine if there's anything that discriminates the patients that are still working now and those that are on Social Security disability. What's the difference between them? And we find when we look at the cognitive tests, as we expect and have seen before, that the cognitive tests discriminate those two groups statistically. SDMT is the most sensitive at that process. And the raw score decline on SDMT is 4 points. That decline of 4 points is the maximum discrimination point between the two groups. So this is another way of thinking about clinically meaningful change. That way, if someone drops 4 points on SDMT, or there's a difference between a treated group and a non-treated group of that magnitude, it could be argued that that's clinically meaningful. So Bianca mentioned that one of the things that I have done with my work in the MS field is to try to reduce the amount of time taken to evaluate patients clinically and also in research trials. And we've made some headway in that, but I can remember when we came out with the McFims battery, 90 minutes, and everybody thought, wow, only 90 minutes. Now 90 minutes seems like forever. We can't do 90 minutes, we got to do something much shorter than that. So on we go. We're trying to reduce and reduce and reduce. And this past year, there have been 2 task forces or panels convened on this topic. One of them is this brief international cognitive assessment for multiple sclerosis, which is a combination of neuropsychologists and neurologists from around the world. And then the other one is this common data element working group with the NINDS. This is a very interesting project. We are looking for consensus on the question, should the government, when they fund research studies in MS, insist on certain data elements that the public then will have access to, data on those data elements, in future work and for open access to that data. We would assume that any MS study would have age and education and race and gender and EDSS and disease course and things like that. And so the government may say, well, okay, we're going to give you, doctor, your NIH grant, but you have to have these data elements in the study or else you won't be funded. So a question came up, well, should there be imaging common data elements? Should there be biospecimens common data elements? Should there be cognitive common data elements? And that's kind of a bold move. Cognition isn't affected in all patients. Should we actually have to measure that in a study? And so I chaired our subgroup, and we did propose a briefer battery than the McFINs, but we didn't say that all of these tests should be common data elements. We thought that that was too much. But we did propose, and this is the way it sits now, that the simple digit modalities test be a common data element. And that's out for public opinion right now. You can go to the website and say you don't like that idea if you want. But this is something that has been finalized now and is at the point of responding to public opinion. The BICAMS battery that I mentioned is the CVLT, BVMT, and the simple digit, three fairly brief tests. Quickly, I want to mention the adaptability of SDMT to the MSFC. So Dr. Coyle told you about the MSFC. It's a combination of timed 25-foot walk, the 9-hole peg test, and the PACE-AT. And there is a task force. I'm on the task force for revising the MSFC. We had a first meeting about, well, it was in December. And there is quite a keen interest in having cognition in the MSFC, but we've got to get rid of the PACE-AT for a lot of different reasons. And so, anticipating this, we looked at SDMT and pretended that that was in the MSFC and did a lot of psychometrics and normalization of that data, which is all in that paper. What I will tell you is that if you replace the simple digit modalities test, you get similar reliability coefficients over 2 years, and you get slightly better sensitivity to deterioration over time. 46% of patients with the simple digit version show a decline of any kind over 2 years, however minute, whereas 28% of PACE-AT patients do. So, in conclusion, I think that we've identified definitively, there's no question that measures of mental speed and episodic memory, these are the key areas that we need to look at with MS. And we do have a pretty good handle on some good candidate measures. In a clinical trial on CCSVI, I would certainly encourage the use of SDMT and then a few other tests involving episodic memory as a kind of a core brief battery that could be done. But we do need to do some more work in the area of clinically meaningful change and longitudinal normative data. Thank you for your attention.
Ralph, I have a question and comment for you. You know, it was extremely important for the society to have you here and give this, I think, extremely important talk because you know, one thing that as a society we try to achieve is, you know, in all these studies, both controlled and open label that are ongoing on endovascular basis, we try to make some standards. And even on this meeting, we saw presentations that were, you know, alluding patients improved, you know, to more sophisticated ones that use some tests. Can you comment, given the non-interdisciplinary approach in most of the clinics that are, you know, dealing with the CCSVI treatment, what would be the way to capture some of this quality of life, cognitive data, when, you know, SDMT cannot be done? Or do you think that given that you were able to teach in one session a test that can be done in 5 minutes, that this would be a very good thing for this audience to say, hey, let's learn how to do the SDMT, and at least all of us will do a 5-minute test in these open label vascular trials that are ongoing and those that are controlled. And what about fatigue and other points? Did you find SDMT to be predictive of other domains than just cognition?
Okay, so there's two components to that inquiry, I think. One has to do with the wider scope of psychological phenomena that you want to maybe pay attention to, and then do we really think that SDMT is the way to go with this? And beginning with the second part, yes. I mean, this is very easy to do. You know, if you were to get, it looks like, based on the common data elements, that if you were to try to get funded by NIH to do a CCSVI study in a few years, they may insist that you do the SDMT. It's very easy to administer. Nurses can do it. Well, I don't know about secretaries, but you know, paraprofessional people can easily do this. So I don't see any reason not to do it. I mean, it takes such little time and little effort. You can easily. One of the issues with SDMT is that it's a visual test. So there is some common variance probably with ocular motor functioning, although we've proposed looking at that. We haven't actually been funded yet to do that, but intuitively that's probably the case. And it doesn't involve memory. So if you want to be able to say something about the patient's memory after your study, then you need to build a memory test around the SDMT, which is also very easy to do, but it takes another 5 or 10 minutes in addition to that. The wider scope question, you mentioned quality of life, you mentioned fatigue. The problem with assessing those areas, and it's fine to do that, but you have a huge bias inherent in all that, and that's self-report and depression. Self-report's correlated with self-report, it's correlated with self-report. If you're unhappy, if you're depressed, you're going to have a poor quality of life because you're going to say you're unhappy about your life. And you're going to complain more about fatigue because you're going to notice pain, fatigue, anything that's adverse or somatic, you're just going to notice that more. So they're all intercorrelated, and they're all poorly correlated with what people can do. There's very poor correspondence between fatigue and walking speed, and there's poor correspondence between fatigue and cognitive performance. There's you know, it's not completely absent, but it's not very robust. Okay? Question?
Dr. Benedict, thank you. I would like to know if, in your opinion, your experience, the SVT can be a performance that could be affected by placebo effect or not.
The SDMT?
Yes,
Oh,
your opinion.
Yeah, I think so. And there are practice effects with taking the test as well. So, yeah, I think so. I think it would respond to a placebo effect just like any other of our neurologic clinical outcomes would. And so let's think about EDSS and SDMT. I think both of those would be equally vulnerable to placebo effect. You have the additional problem with SDMT of there being a learning effect, that we call this, or a practice effect. There's familiarity with taking the test. And you can get around that somewhat by using alternate versions of it. And that's a whole other topic about getting those alternate versions and standardizing them. But assuming that you have them, then that will overcome some of the problem. But nevertheless, there are going to be some of those learning effects. But if you have a control group in your trial design, that's not a problem.
So you may think that it's not necessary to have a double-blinded. You need just of a control group, or do you need
well, I think you need
double-blind?
I think you need a double blind to be certain from a design perspective overall. That's my opinion about that. But I don't see anything particularly special about SDMT compared to other clinical outcome measures with regard to those issues.
Thank you.
Other than the learning effect I mentioned.
This is very interesting. There's been a lot of criticism about the Facebook phenomenon for bypassing medical establishment, and this SDMT seems like a perfect candidate for self-reporting and doing large-scale data collection and extraction from large data. If you, instead of reading from a piece of paper, give people an iPhone app where they can, talk to Siri and maybe get a test that changes so they can't really learn the symbols. It seems like you could get a lot more data over a lot more people.
Yeah, I agree. one of the reasons that SDMT is as reliable as it is because it's administered the exact same way to all patients. The problem with the iPhone application is that some people are going to be doing it on an iPad, some people are going to have the TV on while they're doing it, some people are going to have just had a cocktail, some people haven't. There's 100 variables that can come into play with affecting those data.
Traffic getting to the doctor's office, some people...
Right, exactly. And so, you know, I'm very keen on that idea, and in fact, I am looking into it. But the ideal of being able to do it that easily and have a reliable outcome measure that meets the standards that I've been talking about is another step.
Well, that graph you showed, I mean, having the equivalent graph and looking at its shape would be really interesting.
Yeah, absolutely. Yeah, points well taken.
One more thing. Can you comment on, I know you are avoiding the CCSVI question, but can you comment on our premise study and when you designed the battery, I mean, do you see that the tests for this type of problem we are dealing with, which might be more on a vascular basis, should have other outcomes evaluated than we are usually doing for MS patients? Because, you know, our goal might be really different here. And did you think about that? And can you comment on a premise battery? And maybe even we missed that.
Yeah, you know, the premise battery is based on MS. And I think it's ideally designed for MS. Many of these consensus opinion tests are in our brief battery in the premise study. The issue you're raising is a very interesting one. I've really never thought of it. Is there a different configuration of defects in a CCSVI syndrome than in typical MS? So our outcomes are targeted on helping MS, but you know the data that I can't remember who presented it, but there was some data on normal aging in CCSVI. What about CCSVI and Parkinson's? And should you then, is there any kind of unique effects of the CCSVI syndrome? I don't know. It's a very fun and interesting question to think about. I would have to cogitate more and look at some literature to answer that.
I'm going to give a talk this afternoon about how to design studies and stuff like that. And so this has been actually very helpful. First of all, I want to congratulate the entire Buffalo team. The amount of pressure and abuse that has been thrown upon that group, especially at ECTRIMS, which was the low point, I thought, and they had essentially the same data we see now. I wish they could see some of the data we've seen this week, and hopefully they will. But probably, maybe the most frequent positive result I get from patients who've had this have said it lifts the fog. Comment.
The fog, in general, and not just in MS, and this is a sort of a internal meta-analytic clinical kind of impression, is correlated with actual ability about 0.2. It's a subjective sensation. So if you have that fog and I give you the SDMT, the fog is probably not going to impact very much your ability to do the SDMT. It may distract you from engaging in it because you don't feel well. And, but it's very much like fatigue in that way. So if you get a study done and you find an impact on this fog measure, whatever one you use, fatigue severity or some sort of MSNQ would pick this up, but you don't get an impact on a performance-based measure, then you're probably not affecting the neuropsychological capacity of the patient. You're affecting their subjective sense of distress, pain, fatigue, or whatever. Not that that's not important, it's just not the same thing. Thanks.